I'm going to follow on from Barry in thinking about CAMHS as if it was a patient. But I'm going to hopefully try and just introduce one or two reflections on what it might be helpful for us to attend to if we're going to have a successful treatment of the patient. And really, essentially, in the next 10 minutes, I just really want to convey two key ideas. But because my slides are really confusing, I thought I'd tell you the ideas at the beginning, and then you can see if you can work them out from the slides as we go. Okay. The two ideas, essentially, I'd like you to think about as I go, is one of which is that CAMHS has a history. It has a developmental, experience, just like the patients that we come to see. And I would invite us that it might be helpful for us to just be a little mindful of the developmental history of CAMHS in order to make this very exciting project work well. The second is, a rather obvious thing from somebody coming from a CBT perspective, is that it's not the thing itself that may be critical, but the perception of the thing. So we need to pay a little attention to the type of cognitions that transformation may arouse in the services that we are trying to transform. Transform has many meanings, which I will come to explore very briefly in this presentation. Okay, so what's the matter with CAMHS? What sort of treatment does CAMHS need? Let's imagine I feel, this is probably a bit of a personal point of view here, that I feel a bit like a long-term patient in this process. I've worked in CAMHS for rather a lot of years. I can't quite compete with Peter's 35, but I'm getting close. I feel here this is I'm a patient that's had quite a few treatments already. And this may be a very promising one that's come along and everyone's very enthusiastic about it, but I have had previous treatments, I'm afraid, folks. I'm going to just illustrate one or two treatments that I've had. And I suppose I also want to just explore the idea of using a sort of health anxiety model to my condition, i.e. that the thing about the health anxiety model is that I may have a very different formulation of my needs compared to my therapist. Okay, right. So some of the beliefs that might be around, some of the sort of beliefs and assumptions that might be around as to what I need treatment for is, no, this is true, and Peter gave one or two very interesting kind of elaborations about this morning, but one of them might be that CAMHS outcomes are poor, that we use rather outdated methods, and that what the assumptions of the treatment are is that we've got to empower young people to change us, folks, maybe. If we don't measure outcomes, then we aren't going to improve, etc. Okay. Now I'm going to risk going on a little bit of a detour just for a second here, folks. So just bear with me. Okay. You will all be familiar with this. This is a theory. This is a developmental theory of change. You all know this one. Okay. So it's thesis, antithesis, and synthesis. Okay. What is the interesting? God. Okay. Saying don't go there. Okay. The interesting thing about Hegel's theory was that in every thesis, there is within it an incompleteness. This is why an antithesis arises. The Marxist idea has got the highest prominence. But why an antithesis arises is because every idea has something missing. So out of that arises a third idea. Now, I just want to apply this to something we're not maybe quite so identified with. If we look at social work, we now have a program called Reclaiming Social Work. Now, okay, so let's just map this out. So if we go back about 10 years, we have Laming, comes along with very, very strong lines around improving accountability, supervision, documentation. Actually, many, many people worked extremely hard in social care organizations to, within the standards that they were invited to, improve standards around these areas. Okay, what do we have now? We have Monroe comes along and says, oh, no, we've lost social work somehow. Those people have been working for the Labeling principles didn't think they were losing social work. But now we have Monroe comes along and says, no, that's not the deal. We need to emphasize client relationships, flexible practice, and practitioner autonomy. So we move from one, so in every idea, there is the potential for an idea to be missing. I don't know what the synthesis is going to be of that. I want to apply the same model to CAMHS. So if we go back, some of the treatments that CAMHS have had in the past, probably one of the biggest is Every Child Matters, of which the principles of service integration, mental health as part of the wide outcomes for all services working with children, was combined with also the laming kind of initiatives, which was around also about accountability and supervision. Clearly, the Bristol inquiry, huge impact on services as to who is responsible when things go wrong. Okay. And I think there are also, there are always, pragmatic barriers too. I mean, unfortunately, as we laugh about merrily, but IT systems rarely keep their promises. So some things also restrict the capacity to progress in the way that we would anticipate. So out of that, now this is just my version. So you get some degree of integration out of Every Child Matters. You get the impulse for accountability and need for clearer reporting to reduce risk. And I think out of those two things, laming and the Every Child Matters initiative, you had, I think, some synthesis of things to do with, there was a limited service integration, not as ambitious, not as comprehensive as was originally envisaged in the documentation. There was, though, an increasing, I think, strategic collaboration, but there was also, I think, increasing anxiety within professions as to exactly their position within this emerging new type of service provision. So out of that, it seemed to me what IAPT has built has built on is there has been, and you guys I think are a testimony to that, because all the applications illustrated strong strategic collaboration. But now what is being invited in this is a stronger emphasis on evidence-based practice, and resulting in a huge emphasis on measuring effectiveness. This is great. I'm not here to dampen the party, folks, but I suppose what I would invite is I think we will do better with this program if we can think about what it is that within IAPT may be missing, in order to avoid unhelpful oscillations between different polarities of what may be part of an effective service. So my question is, what reorganization is likely to happen, not after the next one, but after the one after that? Because we know that every reorganization, every initiative has within it the idea that this is it, folks. And what we need to think, if we think clever, is we think, where are we going to be after after this initiative? Because it seems to me this is the critical question to be asked. Okay, quickly, in 3 minutes, this is how CBT, we do it really fast. Okay, okay. So this is the patient has, in health anxiety, the patient has a strong belief in being unwell. It's not me, it's my body. So for CAMHS, I'm short of staff, I'm poorly resourced, I'm poorly managed, I'm in terrible NHS trusts, they're rubbish. And, but no, the government comes along saying, no, it's not that at all, it's a skills problem. It's you, folks. We've got to train you, and you need to handle things differently. Okay. The point of this is that we've got to be careful how we present this. Your service needs to be transformed. Now, this can be read as, oh, they think I'm rubbish. So how does that make me feel? Makes me feel depressed or stressful. But here, I think, is the rub. It can lead to safety behaviors. Safety behaviors and reassurance seeking. That means I'll get trained. Ah, didn't think that was coming. Okay. Now, let's go the other way around. Okay. Okay, your service needs to be transformed. They think I'm worth investing in. Okay? Right, that makes me feel better. I feel excited, I'm enthusiastic, I'm energetic. Okay. Now. It's a plot. Okay. that I'm engaged in the improvement process. I think there is a huge difference, and what I really was thrilled this morning by the speakers, because there is a huge difference between being engaged in this process out of seeking for safety and an engagement in this process, which is engagement in improvement. Because the truth of it, and if I can reveal it, folks, and some of you have always suggested this, is that the people at the front actually don't know the answers. It is one of the things that is, I think, interesting about the IAPT program is there is a real kind of view that this has to be, I think it's a three-way street, actually. There's some lead from the centre, there needs to be some perception from young people, some perception of young people, but there also has to be engagement with frontline services as to what you know actually what works. Now, this is session-by-session monitoring. Okay, so this is a young child who's going to give the therapist a rating on the session. Now, of course, this won't happen. But again, we've just got to play this intelligently. We've just got to play this intelligently. Just having a method in itself, I think, is the risk. Okay. So for me, IAPT is a highly ambitious program, one that I absolutely welcome. But we need to ensure that we listen to the patient who is being treated. CAMHS services have a vast amount of experience that we need to bring on board in this process of transformation. If they feel transformed by people outside, this is going to be troublesome. And I think we need to take into account of the recent history of services. Thank you very much.